Continuation of the endocrinology portion. Low blood pressure volume and low blood pressure stimulate ADH secretion, vasoconstrictor effects of ADH. Although minute concentrations of ADH cause increased water conservation by the kidneys, higher concentrations of ADH have a potent effect of constricting the arterioles throughout the body and therefore increasing the arterial pressure. For this reason, ADH has another name, vasopressin, which you might have heard earlier. So one of the stimuli for causing intense ADH secretion is decreased blood volume. This occurs strongly when the blood volume decreases 15 to 25% or more. The secretory rate then sometimes raises to as high as 50 times normal. The cause of this effect is the following. The atria have stretched receptors that are excited by overfilling. When excited, they send signals to the brain to inhibit ADH secretion. Conversely, when the receptors are unexcited as a result of underfilling, the opposite occurs with greatly increased ADH secretion. So, decreased stretch of the baroreceptors of the carotid, aortic, and pulmonary regions also stimulate ADH secretion. For further details about this blood volume pressure feedback mechanism, we will be learning later that. So, oxytocin hormone. Oxytocin causes contraction of the pregnant uterus. The hormone oxytocin, in accordance with its name, powerfully stimulates contraction of the pregnant uterus, especially towards the end of gestation. Therefore, any observations believe that this hormone is at least partly responsible for causing birth of the baby. This belief is supported by the following facts. In a hypophysectomized animal, the duration of labor is prolonged, indicating a possible effect of oxytocin during delivery. The amount of oxytocin in the plasma increases during labor, especially during the last stage, and stimulation of the cervix in a pregnant animal elicits nervous signals that pass to the hypothalamus and cause increased secretion of oxytocin. This effect and its possible mechanism for aiding in the birth process is discussed later. We'll be learning that later. Oxytocin aids in milk ejection by the breasts. Oxytocin also plays an especially important role in lactation, a role that is far better understood than its role in delivery. In lactation, oxytocin causes milk to be expressed from the alveoli into the ducts of the breast so that the baby can obtain it by suckling. This mechanism works. The suckling stimulus on the nipple of the breast causes signals to be transmitted through sensory nerves to the oxytocin neurons in the paraventricular and supraoptic nuclei in the hypothalamus, which causes release of oxytocin by the posterior pituitary gland. The oxytocin is then carried by the blood to the breasts, where it causes contraction of myoepithelial cells that lie outside and from a lattice work surrounding the alveoli of the mammary glands. In less than a minute after the beginning of suckling, milk begins to flow. This mechanism is called a milk letdown or milk ejection. It is discussed later. So, functions, regulation, and other aspects we just mentioned. Then, disorders of posterior pituitary hormone secretions, antidiuretic hormone failure to produce ADH, central diabetes insipidus. An inability to produce or release ADH from the posterior pituitary can be caused by the following: head injuries, infections, or congenital causes, because the distal tubular segments cannot reabsorb water in the absence of ADH. This condition is called central diabetes insipidus, results in the formation of large volume of dilute urine with urine volumes that can exceed 50 liters per day. The thirst mechanism are activated when excessive water is lost from the body. Therefore, as long as the person drinks enough water, large decrease in body fluids water do not occur. The primary abnormality observed clinically in people with this condition is the large volume of dilute urine. However, if water intake is restricted, as can occur in a hospital setting when fluid intake is restricted or the patient is unconscious because of a head injury, serves dehydration can rapidly occur. The treatment for central diabetes insipidus is administration of a synthetic analog of ADH, desmopressin, which acts selectively on V2 receptors to increase water permeability in the late distal and collecting tubules. So desmopressin can be given by injection as a nasal spray or orally, and it can rapidly restore urine output towards normal. Then inability of the kidneys to respond to ADH, nephrogenic diabetes insipidus. In some circumstances, normal or elevated levels of ADH are present, but the renal tubular segments cannot respond appropriately. This condition is referred to as nephrogenic diabetes insipidus because the abnormality resides in the kidneys. This abnormality can be due to either failure of the countercurrent mechanism to form a hyperosmotic renal medullary interstitium or failure of the distal anticollecting tubule and collecting ducts to respond to ADH. In either case, a large volume of dilute urine are formed, which tend to cause dehydration unless fluid intake is increased by the same amount as urine volume is increased. Many types of renal disease can impair the concentrating mechanism, especially those that damage the renal medulla. Also, impairment of the function of the loop of Henle, as occurs with diuretics that inhibit electrolyte reabsorption by this segment, such as furosemide, can compromise urine concentrating ability. Furthermore, certain drugs such as lithium used to treat manic depressive disorders and tetracyclines used as antibiotics can impair the ability of the distal nephron segments to respond to ADH. Then nephrogenic diabetes insipidus can be distinguished from central diabetes insipidus by administration of desmopressin, the synthetic analog of ADH. Lack of a prompt decrease in urine volume and an increase in urine osmolarity within 2 hours after injection of desmopressin is strongly suggestive of nephrogenic diabetes insipidus. The treatment for nephrogenic diabetes insipidus is to correct, if possible, the underlying renal disorder. The hypernatremia can also be attenuated by a low sodium diet and administration of a diuretic that enhances renal sodium excretion, such as a thiazide diuretic. Then syndrome of inappropriate antidiuresis, SIAD. In 1957, Schwartz and group described the syndrome of inappropriate secretion of antidiuretic hormone, SIADH, which was characterized by inappropriate release of ADH. More recently, it has been observed that not all the affected patients had elevated blood levels of ADH, and therefore the term syndrome of inappropriate antidiuresis has been proposed. So SIED is a syndrome of sodium and water imbalance and manifested by hypertonic hyponatremia and impaired urinary dilution. This feature occurs in the absence of kidney disorders or any other particular non-osmotic stimulus known to release ADH. So SIAD can be caused by various factors, and these are broadly classified as endogenous causes, exogenous causes, and idiopathic causes. So endogenous causes are further classified as ADH secretion being increased from the hypothalamus, ADH from ectopic production such as carcinomas and drugs that potentiate ADH effect. Then exogenous causes include administration of ADH or analogs such as desmopressin. So SIAD is diagnosed based on certain essential features such as a decrease in effective plasma osmolality, an increase in urinary osmolality, and increase in urinary sodium, clinical euvelomia, normal thyroid and adrenal function, and no history of recent use of diuretic agents. So other features include a reduced serum uric acid level and reduced blood urea nitrogen, a fractional sodium excretion, a fractional urea secretion. There could also be a failure to correct hyponatremia even after infusion of 2 liters of 0.9% of saline, and sometimes hyponatremia can be corrected by fluid restriction. Elevation of ADH levels and plasma even in the absence of hypertonicity and clinical euvolemia is another feature that may be seen. The management of this condition includes ruling out and addressing all correctable causes, correcting the hyponatremia, restricting fluid intake, encouraging dietary intake of salt and protein, and administrating vasopressin receptor antagonists if hyponatremia persists. Then next topic, we are going to learn about thyroid gland. We will be starting this portion. You won't be completing this in this session, but you will be learning this. Okay. The thyroid gland is one of the largest of the endocrine glands normally weighing 15 to 20 gram in adults. The thyroid secretes two major hormones, thyroxine and triiodothyronine, commonly called T4 and T3 respectively. Both of these hormones profoundly increase the metabolic rate of the body. Thyroid secretion is controlled primarily by thyroid stimulating hormone or TSH secreted by the anterior pituitary gland. The thyroid gland also secretes calcitonin, and a hormone involved in calcium metabolism. The purpose of this chapter is to discuss the formation and secretion of the thyroid hormone, their metabolic functions, and regulation of their secretion. First, synthesis and secretion of the thyroid metabolic hormone. About 93% of the metabolically active hormones secreted by the thyroid gland are thyroxine, and 7% is triiodothyronine. However, almost all the thyroxine is eventually converted to triiodothyronine in the tissues. So both are functionally important. So triiodothyronine is about 4 times as potent as thyroxine, but it is present in the blood in much smaller quantities and persists for a much shorter time compared with thyroxine. And physiological anatomy of the thyroid gland. The thyroid gland is composed of large quantities of closed follicles that are filled with a secretory substance called colloid and lined with cuboidal epithelial cells that secrete into the interior of the follicles. The major constituent of colloid is the large glycoprotein thyroglobulin, which contains the thyroid hormones. The thyroid gland has a blood flow about 5 times the weight of the gland each minute, which is a blood supply as great as that of any other area of the body, with the possible exception of the adrenal cortex. So when we try to learn about the anatomy and microscopic appearance of the thyroid gland, you could see, you won't be seeing that, you need to search for the image, but portions include larynx, thyroid gland, trachea, and we enlarge that thyroid gland. You could see follicle, capillary, seed cell, cuboidal epithelial cells, red blood cells, colloid, follicle, capillary, C cell, follicle, capillary, C cell, cuboidal epithelial cells, red blood cells. The thyroid gland also contains C cells that secrete calcitonin, a hormone that contributes to regulation of plasma calcium ion concentration. Iodine is required for formation of thyroxine. To form normal quantities of thyroxine, about 50 mg of ingested iodine in the form of iodides are required each year, or about 1 mg per week. To prevent iodine deficiency, common table salt is iodized with about 1 part sodium iodide to every 100,000 parts sodium chloride. Fate of ingested iodides. Iodides ingested orally are absorbed from the gastrointestinal tract into the blood in about the same manner as chlorides. Normally, most of the iodides are rapidly excreted by the kidneys, but only after about 1/5 are selectively removed from the circulating blood by the cells of the thyroid gland and used for synthesis of the thyroid hormones. And formation and secretion of thyroglobulin by the thyroid cells. The thyroid cells are typically protein secreting glandular cells. Thyroglobulin, a large glycoprotein molecule, is synthesized by the endoplasmic reticulum and Golgi apparatus and secreted into the follicles. Each molecule of thyroglobulin contains about 70 tyrosine amino acids, and they are the major substrates that combine with iodine to form the thyroid hormones. Thus, the thyroid hormones from within the thyroglobulin molecule. Then iodine pump, the sodium iodine support, iodine trapping. The first stage in the formation of thyroid hormones is transport of iodides from the blood into the thyroid glandular cells and follicles. This pumping is achieved by the action of a sodium iodide supporter, which co-transports one iodide ion from with two sodium ions across the basolateral plasma membrane into the cell. The energy for transporting iodide against a concentration gradient comes from the sodium potassium adenosine triphosphate. So which pumps sodium out of the cell, thereby establishing a low intracellular sodium concentration and a gradient for facilitated diffusion of sodium into the cell. This process of concentrating the iodine in the cell is called iodine trapping. The capacity of this pump helps concentrate iodide 30 times that of blood normally and up to 20 to 50 times during maximum activity of the gland. The rate of iodine trapping by the thyroid is influenced by the concentration of TSH. A protein called pentyl iodide ion counter transporter helps transport iodide out of the thyroid cell into the follicle. Then oxidation of the iodide ion. The first essential step in the formation of thyroid hormones is conversion of iodide ions to an oxidized form of iodine, either nascent iodide or from which is then capable of combining directly with the amino acid tyrosine. This oxidation of iodine is promoted by the enzyme peroxidase and its accompanying hydrogen peroxide located in the apical membrane of the cell or attached to it. When the peroxidase system is blocked or when it is hereditarily absent from the cell, the rate of formation of thyroid hormones falls to zero. Then iodination of tyrosine and formation of the thyroid hormones, organification or thyroglobulin. The binding of iodine with the thyroglobulin molecule is called organification of the thyroglobulin. In thyroid cells, the organized iodine with the help of thyroid peroxidase enzyme causes the process to occur within seconds or minutes. Tyrosine is first oxidized to monoiodotyrosine and then to diiodotyrosine. Then coping of iodotyrosine residues. Immediately after the formation of monoiodotyrosine and diiodotyrosine, during the next few minutes, hours, and even days, more and more of the iodotyrosine residues become coupled with one another. The major hormone products of the coupling reaction is the molecule thyroxine, which is formed when two molecules of diiodotyrosine are joined together. The thyroxine then remains part of the thyroglobulin molecule, or one molecule of triiodotyrosine couples with one molecule of diiodotyrosine to form triiodotyrosine tyronin T3, which represents about 1/15 of the final hormones. Small amounts of reverse T3 or T3 are formed by coupling of diiodotyrosine with monoiodotyrosine, but RT3 does not appear to be of functional significance in humans. And storage of thyroglobulin. The thyroid gland is unusual among the endocrine glands in its ability to store large amounts of hormone. After synthesis of the thyroid hormones has run its course, each thyroglobulin molecule contains up to 30 thyroxine molecules and a few triiodothyronin molecules. In this form, the thyroid hormones are stored in the follicles in an amount sufficient to supply the body with its normal requirements of thyroid hormones for 2 to 3 months. Therefore, when synthesis of thyroid hormones ceases, the physiological effects of deficiency are not observed for several months. Then release of thyroxine and triiodothyronin from the thyroid gland. Most of the thyroglobulin is not released into the circulating blood. Instead, thyroxine and triiodothyronin are cleaved from the thyroglobulin molecule and then these free hormones are released. About 3/4 of the iodinated tyrosine and the thyroglobulin never become thyroid hormone but remain monoiodotyrosine and diiodotyrosine. During the digestion of the thyroglobulin molecule, their iodine is cleaved from them by a deiodinase enzyme that makes virtually all this iodine available again for recycling within the gland. So, in the congenital absence of this deiodinase enzyme, many persons become iodine deficient because of the failure of this recycling process. So, process of release of thyroxine and triiodothyronin from thyroid gland. Thyroid cells at their apical surface extend pseudopod extensions around small portions of the colloid to form pinocytic vesicles. These penocytic vesicles enter thyroid cell. Lysosomes fuse and digest the thyroglobulin in the penocytic vesicles. Then thyroxine and triiodothyronine in free form are released into the cell. T3 and T4 diffuse out of the thyroid cell into surrounding capillaries, thus entering into the cell. Then daily rate of secretion of thyroxine and triiodothyronine. About 93% of the thyroid hormone released is thyroxine, and approximately 7% of the thyroid hormone is released is triiodothyronine. However, during the ensuing few days, about one half of the thyroxine is slowly deiodinated to form additional triiodothyronine. Therefore, the hormone finally delivered to and used by the tissues is mainly triiodothyronine, a total of about 35 mg per day. And transport of thyroxine and triiodothyronine to tissues. Thyroxine and triiodothyronine are bound to plasma proteins upon entering the blood. More than 99% of thyroxine and triiodothyronine combines immediately with several of the plasma proteins, all of which are synthesized by the liver. They combine mainly with thyroxine binding globulin and much less so with thyroxine binding prealbumin and albumin. Thyroxine and triiodothyronine are released slowly to tissue cells. Because of high affinity of the plasma binding proteins for the thyroid hormones, these substances, in particular thyroxine, are released to the tissue cells slowly. Half the thyroxine in the blood is released to the tissue cells about every 6 days, whereas half the triiodothyronine, because of its lower affinity, is released to the cells in about 1 day. Upon entering the tissue cells, both thyroxine and triiodothyronine again bind with intracellular proteins, with the thyroxine binding more strongly than the triiodothyronine. Therefore, they are again stored, but this time in the large target cells themselves, and they are used slowly over a period of days or weeks. Thyroid hormones have slow onset and low duration of action. Long duration of action. So, after injection of a large quantity of thyroxine into a human being, essentially no effect on the metabolic rate can be discerned for 2 to 3 days. Once activity does begin, it increases progressively and reaches a maximum in 10 to 12 days. Thereafter, it decreases with a half-life of about 15 days. Some of the actively persists for as long as 6 weeks to 2 months. The actions of triiodothyronine occurs owing 4 times as rapidly as those of thyroxine, which is a latent period as short as 6 to 12 hours, and the maximal circular activity occurring within 2 to 3 days. Most of the latency and prolonged period of action of these hormones are probably caused by their binding with proteins both in plasma and in tissue cells, followed by their slow release. And metabolism and excretion of the thyroid hormones. Most of the thyroxine secreted by the thyroid is converted into triiodothyronine before acting on target tissues. One iodide is removed from almost all the thyroxine, thus forming triiodothyronine. Intracellular thyroid hormone receptors have a high affinity for triiodothyronine. There are 3 deiodinase enzymes, of which D1 and D2 are responsible for most of the peripheral conversion of T4 to T3. Consequently, more than 90% of the thyroid hormone molecule that bind with the receptors is triiodothyronine. The third deiodinase enzyme, present in tissues such as liver, skeletal muscle, and CNS, is responsible for inactivating T3 and also prevents the activation of T4 by converting it into reverse T3. Following inactivation, these hormones are conjugated with sulfates to form T4SO4 or T3SO4. Alternatively, they are conjugated with glucuronides to form glucuronidated T4 and T3 and excited into the bile. However, in the intestine, there may be partial reabsorption after deglucuronidation. Physiological functions of thyroid hormone. Thyroid hormone increase transcription of large number of genes. The general effect of thyroid hormone is to activate nuclear transcription of large number of genes. Therefore, in virtually all cells of the body, great number of protein enzymes, structural proteins, transport proteins, and other substances are synthesized. The net result is generalized increase in functional activity throughout the body. Then thyroid hormones activate nuclear receptors. The thyroid hormone receptors are either attached to the DNA genetic strands or located in proximity to them. On binding with thyroid hormone, the receptors become activated and initiate the transcription process. Then large number of different types of messenger RNA are formed, following within another few minutes or hours by RNA translation on the cytoplasmic ribosome to form hundreds of new intracellular proteins which cause most of the effects of thyroid hormones. The non-genomic cellular effects of thyroid hormone, which are the thyroid hormone, also appear to have non-genomic cellular effects that are independent of their effects on gene transcription. Non-genomic actions of thyroid hormone include the following: regulation of ion channels, regulation of oxidative phosphorylation, activation of intracellular secondary messengers such as cyclic AMP or protein kinase signaling cascades. The site of non-genomic thyroid hormone action appears to be the plasma membrane, cytoplasm, and perhaps some cell organelles such as mitochondria and tissues such as the heart, pituitary, and adipose tissue. Thyroid hormone increase cellular metabolic activity. The thyroid hormone increases the metabolic activities of almost all the tissues of the body. The basal metabolic rate can increase to 60% to 100% above normal when large quantities of the hormones are secreted. So, thyroid hormones increase the number and activity of mitochondria. One of the principal functions of thyroxine might be simply to increase the number and activity of mitochondria, which in turn increase the rate of formation of adenosine triphosphate or ATP to energize cellular function. However, the increase in the number and activity of mitochondria could be the result of increased activity of cells as well as the cause of the increase. Then thyroid hormones increase active transport of ions through cell membranes. One of the enzymes that increase its activity in response to thyroid hormone is NAK-ATPase. Because this process uses energy and increases the amount of heat produced in the body, it has been suggested that this might be one of the mechanisms by which thyroid hormone increases the body's metabolic rate. In fact, thyroid hormone also causes the cell membranes of most cells to become leaky to sodium ions, which further activate the sodium pump and further increase heat production. Then effect of thyroid hormone on growth. Thyroid hormone has both general and specific effects on growth. For instance, it has long been known that thyroid hormone is essential for the metamorphic change of the tadpole into the frog. In growing children, those who are hypothyroid, the rate of growth is greatly retarded. In children with hyperthyroidism, excessive skeletal growth often occurs, causing the child to become considerably taller at an early age. However, the bones also mature more rapidly and the epiphyses close at an early age, so the duration of growth and the eventual height of the adult actually may be shortened. An important effect of thyroid hormone is to promote growth and development of the brain during fetal life and for the first few years of postnatal life. If the fetus does not secrete sufficient quantities of thyroid hormone, growth and maturation of the brain, both before and birth and afterwards, are greatly retarded and the brain remains smaller than normal. Without specific thyroid therapy, within days or weeks after birth, the child without a thyroid gland will remain mentally deficient throughout life. So, we just mentioned some topics related to thyroid hormones and thyroid gland, effect of thyroid hormones on growth. And thyroid hormone increase cellular metabolic activity and physiological functions of thyroid hormone, metabolism and excretion of thyroid hormone, transport of thyroxine and triiodothyronine into tissues. Some other aspects related to the oxidation of iodine ion. Then iodine is required for formation of thyroxine while synthesis and secretion of the thyroid metabolic hormones. Thank you for listening. tomorrow we will be continuing with some topics related to thyroid gland, like effects of thyroid hormone on specific body functions. Okay, so some topics related to that, effects of thyroid hormone on specific body functions. Thank you.